Good afternoon. I'd like to welcome you all to the ADNET Memory Clinics webinar. This is the first webinar for 2024. Before we begin, let me acknowledge the traditional custodians of the country throughout Australia and their continuing connection to land, sea, and the community. We pay our respects to all Aboriginal and Torres Strait Islander people, their cultures, and to their elders, past, present, and emerging. Now, before we actually hear our speakers for today, I would like to introduce ADNET briefly to you. Now, most of you know ADNET stands for the Australian Dementia Network. This has now been in existence for nearly 6 years. It's a network of national dementia research experts and health professionals. The initial funding was for 5 years from the NHMRC. Currently, it is being supported by the Federal Department of Health. Now, there are 3 components to ADNET. There is the memory clinics component, and that component is the one that is organizing this seminar. This essentially brings memory clinics around the country together for various coordinated activities, including the development of guidelines for diagnosis and post-diagnostic support. The second component is a registry, a clinical quality registry for all patients with dementia and MCI, initially from memory clinics, but maybe subsequently going to other settings so as to form a comprehensive registry for dementia and MCI in Australia. And the third component is the creation and maintenance of a trial-ready cohort for trials for Alzheimer's disease and other dementias in Australia. Now, one thing that, of course, I should say is that we would like all clinicians who are on the call who are part of Memory Clinic, and if they're not already part of ADNET, they should approach us and perhaps become members of the Memory Clinics network, and also consider participating in the clinical quality registry. And here there are some links as to how you could possibly do that. ADNET also will actually give you updates, so you have to subscribe to the ADNET newsletter for that, and the link for the newsletter is here as well. Essentially, you go to the Australian Dementia Network website, and that should actually guide you to the various clinics and the clinic links, as well as the registry and the newsletter. If you want to be informed about the ADNET memory clinics, then of course the URL for that is also on display here. Now, the other thing I would like to briefly mention is that ADNET organizes the annual Australian Dementia Research Forum. And the one this year is in the Gold Coast between the 3rd and the 5th of June 2024. This is actually the major dementia research event in Australia, and would certainly like all of you to participate actively in this. Of course, the deadline for abstract submission is now passed, but the registrations are open, and we'd like to see you all. In fact, it's the perfect place to meet the dementia research community in Australia. And just to give you a brief overview of this forum, there are 7 national and international keynote speakers, 8 symposia, some of them are listed here. And there are continuing professional development sessions, panel discussions, debates, and of course, networking, which is actually the major focus of the forum. Now, just some housekeeping. If you're having any technical issues during the webinar, please raise your hand. And when I say raise your hand, electronic hand, really. And then Johannes, who is working behind the scenes, is moderating this, or one of his colleagues will address that issue. Also, we would encourage you to ask questions through this. And the way to ask question is to select the Q&A button at the bottom of the screen. just scroll to the bottom. There you see the Q&A button, and you post your question, and they will be collated. And towards the end of the webinar, we will try to address as many of these questions as possible. Now, just to remind you, do not put your question in the chat box. Chat is not for Q&A. It's the Q&A section. So make sure that you do that, please. So it's my great pleasure to welcome you now to the webinar itself. And this webinar is on social determinants of health in aging and dementia. And we have two excellent speakers. Now, I know both these speakers very well because they are colleagues here at the Center for Healthy Brain Aging, which is where I work. The first speaker will be Dr. Suraj Samtani, who is a postdoctoral fellow. And he's a clinical psychologist by background, although his work in the last few years has been largely in social determinants of health. He's been looking at social connections, social cognition, and other aspects of social determinants, well, both in Australian studies as well as internationally. And he's published some excellent work recently. He's currently a Dementia Australia Research Fellow. And he's also, not only is he examining social determinants in observational studies, but he's also designing interventions and currently doing a RCT for a novel social cognitive skills intervention for older adults. Now, our second speaker is Associate Professor Simone Reppermund, who is also, of course, at CHIBA, at UNSW. And her research interests are quite broad in aging, cognitive disorders, and social determinants is actually a more recent focus. And she actually leads the group looking into social determinants of health in aging and dementia at our center. She aims to improve health and mental health outcomes of older people. And one other area that she's worked in quite intensively is looking at measurement of functional disability, which is something that we don't do very well. So really, we are in for a treat. So welcome, both of you, and over to you, Suraj.
Great. So as Parminder mentioned, I'm here to talk to you today about social cognition and dementia, to discuss what are the early warning signs and what are some of the interventions that we can do to help people in this space. So we'll start off by defining what social cognition is before we move on to looking at what are the social cognitive deficits that we see in MCI and dementia. Then we will look at existing interventions and finally move on to a novel intervention that we are trialing at the moment at CHIBA. So let's start off by talking about what is social cognition. Well, we know that to diagnose someone with dementia, we need to see a decline in one or more domains of cognitive functioning, and that includes social cognition. Often this is a domain of cognition that's overlooked in our assessments clinically, and it's quite important because it's associated with a lot of changes in behavior. So for example, it might change the way people react in social situations. They might find it hard to inhibit their behavior, read cues, and also to modify their behavior based on reactions from other people. When we think about social cognition and the brain, we try to look at different domains here. So the ones that are probably studied the most are theory of mind, empathy, social perception, and social behavior. So when we look at theory of mind, which is putting ourselves in someone else's shoes, thinking about what they're going through, this is more where the prefrontal cortex comes in and helps us to project ourselves into their situation. This is different to empathy, which is all about feeling what the other person is feeling. And that's got to do more with the insula and the anterior cingulate cortex. It's this association we have with those feelings. and a visceral sort of reaction when we feel something, we see someone in a certain situation, maybe they're going through a happy moment or a difficult moment, we feel things quite similar to what they're feeling in that situation. Social perception is another domain here, which is quite important, which is being able to look at people's faces, figure out what they're trying to say or communicate with us, either verbally or non-verbally. And this is where the fusiform face gyrus and the amygdala are quite important. And finally, that perception should lead to appropriate social behavior. And this is where the ventral medial prefrontal cortex comes in, thinking about, well, I've got this information, but now how do I react in this situation? What would be appropriate? So in the context of our work with older adults, we not only have these 4 major domains, but we are also dealing with this wrapped up with memory concerns. So people forgetting information from the start of the conversation to later on in the conversation, and sensory issues, people telling us they find it really hard to focus on someone talking to them, especially if they're in a group or a crowded place where there's a lot of echoing. So these are things that people find quite difficult in social situations. And if we now zoom in a little bit further into social cognition, we see that it's not just these 4 major domains, but there's also a lot of subdomains here that are important. Everything from making eye contact to turn taking in social situations. And this is where we start to look at the context of dementia and start to see, well, what are the deficits that we see across these disorders that we can try to pick up clinically early on. One of the things that I like to highlight here is that there is an overlap between theory of mind and empathy. And these are concepts that people often get confused about. So both of them have a cognitive and affective component. So cognitive theory of mind is imagining what another person is thinking, whereas affective theory of mind is thinking about how the other person is feeling. Now, affective theory of mind overlaps a lot with cognitive empathy, which also involves thinking about what other people are feeling here. But then we go beyond this to affective empathy, which is about feeling what others feel. And you'll see later on as we talk about dementia, people with dementia are actually quite good at this affective empathy. They can feel what other people are feeling. It's these earlier types here on your left that they find more difficult, which is putting themselves in someone else's shoes cognitively and imagining how they're feeling. And why is this important? Well, this is important because if someone's having difficulties with social cognition, that will impact their social behavior. And that will impact how they interact with other people. And if they're not responding appropriately in these situations, we see their social network shrink, and that places them at high risk of having poor well-being, maybe getting depressed, anxious. And we know that this also is linked to a higher risk of dementia, because as people feel lonely and have less social support, their risk of dementia increases quite a lot. So how do we clinically assess social cognition? Well, we all know the Sally and Anne story. So this is a false belief task where you tell people Sally and Anne are little girls, they're playing with a doll on a bed. Sally leaves the room for a little while, and while she's gone, Anne hides that doll under the bed. Now Sally comes back into the room. Where is she going to look for the doll? And often this test is used for children, because around the age of 7, children develop theory of mind, and some children don't, especially if they're on the autism spectrum. And children on the spectrum will say, well, of course, Sally's just going to look under the bed. because they can't differentiate between the perspective of Sally and Anne, where we see similar sort of deficits when we use this test with later stages of dementia as well. There's also the TACIT, which is the awareness of social inference test, which looks at recognizing emotions and theory of mind. There's the reading the mind in the eyes test, where you show people pictures of people's, eyes and ask them to choose which emotion the eyes are trying to convey. And Chiba's very own Russell Chander has developed a short version of this test with a cutoff score that you can use. And here's the link if you're interested. There's also the BASD, which is the brief assessment of social skills for dementia. And here you show people static pictures of people's faces, and then static pictures of people in groups, and then a movie clip where something's going on and you have to figure out what it is. So this tests facial recognition and recognition of emotions, as well as empathy or theory of mind, and inhibiting your behavior in social situations. There's also the Edinburgh Social Cognition Test, which we're using currently, and it measures these domains. So I just wanted to show you a brief example of what this test involves. So let's have a look at a practice scenario where you actually show participants a video, and then you jump to the storyboard, which I'm sharing with you here. This woman, she's walking home with her groceries, her bag rips, everything falls to the ground, and the man that crosses her path just keeps walking. Now, in the escort, you ask people, well, what was she thinking and feeling at when this happened? What was she thinking and feeling after the man walked away? And you often get very entertaining and colorful, let's say, answers about what she was thinking and feeling after the man walks away. And you also ask people, what would you do in this situation and what should people do? So here you're testing their ability to, project themselves into her situation. What is she thinking? What is she feeling? And then what are the norms in this situation? If you'd like a broad overview of the different tests of social cognition, in September last year, we published this paper in Frontiers in Psychiatry. And there's a useful table in there for all the clinicians out there that tells you whether the tests are free or they cost money, how many items they include, how long would it take to administer them, and also what are the domains that they assess, so that you can make your own decision about what would be the best test for the person in front of you. Now, what happens to social cognition as we age? Here you can see really great paper that's come out recently looking at the trajectories of the different domains of social cognition with age. And you can see that, as we age, we're actually getting better at feeling what other people feel, this affective empathy, and social behavior stays pretty much stable. But it's our ability to read other people's expressions and project ourselves into their state of mind and the way they're feeling. These are the abilities that tend to decline naturally with age. So how does this then appear? How does this manifest in the context of neurodegenerative disorders? Well, we see that it's impacted in a lot of different conditions, and for our sake here, really impacted in the case of frontotemporal dementia, where you see a lack of inhibition, lack of social filter, people finding it difficult to take turns. And in Alzheimer's disease, it's a little bit more subtle, and there's less research on this, but I'll take you through that shortly. So before we talk about dementia, let's talk about MCI. In the context of MCI, we see very mixed findings, or a lot of null findings, when people compare healthy controls with people who have MCI. But a few years ago, we had this meta-analysis come out, which found moderate deficits in theory of mind and emotion recognition, especially the ability to recognize fear and anger. So you can see here that something might be going on with the amygdala in MCR, because this ability to recognize fear and anger is related to that. Now, what does this look like in the context of dementia? Well, in the context of dementia, we see that people have difficulty identifying facial expressions. Even in mild Alzheimer's disease, they struggle with recognizing disgust, anger, happiness. But it should be noted that at this stage, they're very good at identifying faces, genders of the speakers, and where the speaker's gaze is directed to. And one thing that they find quite easy is to tell what emotion someone is expressing in a static image. But as soon as you start playing a movie or there's a complex situation that evolves over time, they find it sometimes difficult to track these expressions changing over time. Now, in terms of theory of mind, a big meta-analysis from 2020 found deficits in cognitive theory of mind and affective theory of mind, or cognitive empathy, but really intact affective empathy. So again, really, still able to feel what other people are feeling, but finding it hard to put themselves in other people's shoes in terms of what would that person be thinking? What would that person be feeling in this hypothetical scenario? And we see identifying others' intentions can be quite difficult. Cognitive demanding tasks can impair ability to have empathy. So if there's a lot of things that that person is trying to juggle, they might find it hard to put themselves in someone else's shoes. And these abilities do tend to worsen as people progress from mild to moderate dementia. And at the stage of moderate Alzheimer's disease, we see difficulties with inhibition, which you would see very early on with frontotemporal dementia, especially the behavioral variant. So what's a possible solution here? One is that maybe if we help people to boost their social cognition or maintain it and maintain their social engagement, maybe we can reduce their loneliness and their risk of dementia, or maybe just slow down the rate of cognitive decline. So let's talk about some of the existing interventions out there. Well, there aren't many. That's the basic take-home message here. Is there's been one study looking at helping people identify social expressions. They had 36 people with Alzheimer's disease, gave them 20 sessions of this training and compared it to cognitive stimulation therapy, and found that they got better at identifying certain emotions like disgust, fear, anger, so on, by the time the intervention ended. And then there's been other social cognition interventions. So for example, communication skills for couples. This second study here found no effect on quality of life and didn't measure social cognition before and after, even though the intervention was quite social cognitive in its focus. Similarly, this third one here was a dementia cafe or salon type of intervention rolled out to a lot of people in Japan over many years. And they found that the rate of cognitive decline actually slowed down because these people were interacting. But again, they didn't look at social cognition before and after. So while we know it might help global cognition generally, we really don't know how this affects social cognition. And we also don't have interventions that look at multiple domains of social cognition. As you can see, these are quite specific. So that brings us to a new intervention that we're trialing at the moment. And this is called Maintaining Social Engagement. It's an online group program for older adults with memory concerns. So this includes people with subjective cognitive complaints, mild cognitive impairment, and early stages of dementia. And it's in partnership with UQ and Silverchain and funded by the Dementia Australia Research Foundation. So why did we do this? Well, as I said before, there's no comprehensive interventions for social cognition, and there's really none for older adults with existing memory concepts. And what we did, or how we did this, was that we co-designed and piloted a novel intervention. So at the moment, we've completed co-design and pilot, and we have just started the randomized control trial. And we hope in the future to move towards implementing this in care across Australia through aged care providers. So we had an advocates group, an ideas group that came up with this project, and we also had a co-design group who helped us create this intervention. So you can see here we have 5 modules that we take them through. I'll let you have a read. Now, the thing I really want to highlight here is number 3, which is managing sensory and cognitive challenges. This is the one thing they all said, well, all well and good if you can help us, be more social and read people's faces and behavior, but we struggle with this more when we're in crowds and when we're struggling to remember information in conversations. So we made sure to address this directly. So this takes a re-ablement perspective. We assume that people have these skills. We just want them to tap into the skills that they already have and share tips with each other in a group setting of 3 to 4 people. They meet for 2 hours with a 30-minute break in the middle. There's 5 sessions. It's totally online, so anyone from Australia can join. They have discussions. There's a PowerPoint and a booklet that they get, and there's videos that they get to watch. So in our pilot study, we had 10 people, 3 people with dementia, 7 with MCI, and we saw improvements in social cognition and memory recall. But they were very high functioning in terms of their MOCA scores. They were not lonely. They didn't have social frailty. The anxiety and depression scores were almost 0, and they were doing great on activities of daily living at baseline. So we basically had floor effects on all of these other measures. That's why we want to do now a randomized control trial and take people who are actually feeling lonely to see if it helps them. So in this study, we saw improvements on the total score and cognitive theory of mind and interpersonal understanding. And we also saw no change in MOCA scores, but a slight change in their delayed memory. What people said is that they felt more confident after the program. Most of them used the skills each week, and they thought, it really empowered them to use the skills that they had already. They really liked the format. It was online. They enjoyed that, and they enjoyed meeting people from all over Australia. But we intended this to be an in-person intervention, but it was 2020, so there we go. So the next step that we are involved in right now is the project funded by Dementia Australia Research Foundation, and we're partnering with an aged care provider, which is Silver Chain, who send healthcare professionals like OTs, speech therapists, nurses into people's houses in the community, especially in rural and remote areas. So they're based in Western Australia, South Australia, and Victoria. And we're focusing on the phase 1, which is RCT, before we hopefully move on to implementation or knowledge translation later on. So we select people with cognitive concerns. They're older adults age 55 plus. We do a baseline assessment, including the SCOT, the MOCA, telemed version, and some questionnaires. They get randomized into receiving either the intervention or an active control condition where they get to watch videos and have group discussions. So we're trying to control for the amount of socializing. And then they do a post-intervention and a 3-month follow-up assessment. So, I'd like to really thank our team. Iman Shatnawi here is the person doing the before and after assessments, and Tiffany Chow is the one who is randomizing people into their conditions. And I'm really thankful to my mentors on this project, Julie Henry Berdati, Chiba, Tanya Davison, and Marissa Dickens. And special thank you to our advisory group who keep us, on the ground and thinking about how to make this practical, and also to Parminder, because he said, think about interventions and talk to Julie. And here we are a few years later. So thank you. And here, if you know anyone that you're seeing in the clinic that might benefit, if they're showing some memory concerns or early signs of dementia, and you notice that they're quite socially isolated, please direct them towards our study. Here is the QR code. Hopefully the slides will be shared with you after. And thank you very much. That's the end from me. I'll pass it over to Simone.
Thank you for introduction, Parminder, and for inviting me to present on social determinants of health in aging and dementia. I will try to give you an overview of some of the current research in this area. But as a disclaimer, this is a relatively new research area for me, and I won't present results from my own group yet, but rather give you a glimpse of current research and future direction. So let's start to have a look at life expectancies. There are extreme worldwide differences in life expectancies. For example, the life expectancy for a child born in Africa now is about 64 years. And in contrast, a child born in Australia now can expect to live to 83 years. So that's almost 20 years difference. But then even within continents, there are huge differences in life expectancy based on the area of living and based on population groups. So as you can see here, people in the Central African Republic have a 10 years lower life expectancy. And also in Australia, Indigenous people live on average about 10 years less than non-Indigenous Australians. And then in addition to population groups, also the location matters. Even within local geographical areas in a country, there are big differences. For example, life expectancies for Aboriginal and Torres Strait Islander people are highest in New South Wales and lowest in the Northern Territory. These differences illustrate health inequities driven by social determinants. And of course, not only the life expectancy is important, but also the quality of life. Before we come to social determinants in more detail, I would like to briefly explain the term health inequities. The WHO defines health inequities as unfair and avoidable or remediable systematic differences in health among population groups defined socially, economically, demographically, and geographically. Health inequities are not only caused by healthcare and access to healthcare, but by social factors, including education, employment status, income level, gender and ethnicity. They all have a powerful influence on health inequities. And health inequity occurs on a local, national, and global scale, and it affects all countries worldwide. And as the terms are often mixed up, health inequities are not the same as health inequalities. So inequity refers to unfair and avoidable inequalities that are not natural and then avoidable, but it's a product of human behavior. Health inequality, on the other hand, simply refers to a difference in health. Now, what are social determinants of health? Again, the best definition comes from the WHO that social determinants of health can be broadly defined as the conditions in which people are born, grow, live, work, and age, and people's access to power, money, and resources. Interventions and policy addressing social determinants of health, such as early childhood education programs and social protection policies, can have positive effects on health and reduce health inequities. So in this model here, 5 main components of social determinants are shown, access to education and quality of education, access to healthcare and quality of healthcare, the neighborhood and built environment, the social and community context, and economic stability. As shown in this diagram, the fundamental causes of health inequities are an unequal distribution of income, power, and wealth, and this can lead to poverty and marginalization of individuals and groups. And these fundamental causes also influence the distribution of wider environmental influences on health, such as availability of good quality housing, of work, education, and learning opportunities, and also access to services and social and cultural opportunities in an area and in society. The wider environment in which people live and work then shapes their individual experiences of, for example, low income or poor housing, discrimination, and access to health services. And this all results in unequal and unfair distribution of health, in morbidity and in mortality. What works to reduce health inequities? Tackling health inequities requires a blend of action to undo the fundamental causes, for example, by changing policies, prevent the harmful wider environmental influences, for example, by providing accessible quality education, and mitigate the negative impact on individuals, for example, by tailoring individual support. But action must be based on evidence of need, understanding of barriers to social opportunities, and what is most likely to work. This is the last kind of overview slide before I get into more detail of what the title of my talk promised. But I find this figure here quite interesting, as it kind of quantifies the impact of social determinants of health on health outcomes. So how much of an influence do social determinants of health have on an individual's health? This figure here is taken from the county health rankings model in the US, which was done 10 years ago. So this needs to be updated, but I think it demonstrates well the influence of social determinants of health, how a wide range of factors can influence how well and how long we live. So here in the red square are the social determinants of health, clinical care, including access to care and quality of care, social and economic factors, including education, employment, income, family and social support, and community safety, and the physical environment, including air and water quality and housing and transit. And together, these factors account for 70% of health outcomes. However, most research in public health education focuses on health behavior, including smoking, diet, exercise, alcohol and drug use, and sexual activity, which accounts for 30% of health outcomes in this model. So it is clear that a combined approach is needed, individual factors and health behavior education, but also policy changes and environmental changes. Now, why is it important to look at social determinants of health in aging and dementia? Social determinants of health have a major impact on health, well-being, and quality of life as we age. As we all know from the landmark paper by Jill Livingston, as much as 40% of the risk for dementia may be explained by modifiable risk factors. And many of these are in the social context. Social isolation is noted to increase the risk of dementia significantly. And Indigenous Australians have a 3- to 5-fold increased risk of dementia. And this is largely attributable to social determinants. The trajectory of dementia, including the assessment, the treatment and care, life expectancy and quality of life, is very different based on socioeconomic status and ethnocultural backgrounds. Living in a disadvantaged and socially fragmented neighborhood reduces the lifespan and leads to more chronic illness in late life. It can lead to brain abnormalities such as reduced hippocampal volume and to greater dementia risk. And I will give you in the following slides a few examples from current research. One important area are person-environment processes. So for many older people with and without dementia, but actually for younger people as well, a sense of belonging to a group and a community, feeling stability in and familiarity with their environment is important. The life space of individuals and exchange processes between the individual and the environment influences well-being. It influences identity and autonomy. And the different environmental dimensions of an individual's life space, such as the social, physical, care service, technological, and socio-economic environment, have an impact on the aging process. A study by Ryan Powell in the US tried to link neuropathology data to social determinants of health using neighborhood disadvantage metrics. And then they evaluated the associations between neighborhood disadvantage and Alzheimer's disease-related neuropathology. This was a cross-sectional study that looked at donated brains of deceased people with Alzheimer's disease. The sample consisted of 444 brain donors, 56% male and mean age of 80, with the presence of plaques and who had lived in a non-institutional address. Social determinants of health were measured by an area deprivation index at the neighborhood level that included education level, income, housing, and employment characteristics. Most of the sample had lived in the most affluent or least disadvantaged neighborhoods, and only about 5% were from most disadvantaged quintile neighborhoods. You can see here on the map, the darker the color, the more disadvantaged was the area. And brain donors who had lived in the most disadvantaged neighborhoods had the highest risk of Alzheimer's disease neuropathology. Adjusted models showed that with each decile increase in neighborhood disadvantage, there was an estimated 8% increase in the expected odds for Alzheimer's disease neuropathology. So living in the most disadvantaged neighborhood decile was associated with a 2.18 higher odds of AD neuropathology. There are a number of limitations for this study. It was cross-sectional and there was no data on how long the people had actually lived in the specific neighborhoods. And most of the sample lived in less disadvantaged areas. So the results need to be replicated. And of course, the biosocial pathway of the associations between neighborhood disadvantage and Alzheimer's disease remains largely unclear. Its possible factors related to the neuropathology include stress, sleep disruptions, lifestyle factors such as diet and exercise, pollution, and cardiovascular risk factors such as diabetes. But more research is needed to look at this in more detail. Another US study looked at associations between neighborhood level disadvantage and hippocampal volume in cognitively healthy participants. They used cross-sectional data from 951 participants from 2 large ongoing cohort studies. And they found that living in the 20% most disadvantaged neighborhoods was associated with 2% lower total brain volume tissue and 4% lower hippocampal volume. The findings show that neighborhood disadvantage may be associated with brain tissue volume during the aging process, even in the absence of cognitive impairment. But again, this study was also cross-sectional, and so we have to be careful with inferring causality, and only a small proportion of the sample lived in the most disadvantaged neighborhood. But together, these studies suggest that residential location may be a risk factor for brain volume loss and neuropathology during aging. Another really interesting project is Cognability, led by Jessica Finlay at the University of Michigan. So cognability is a new theoretical concept to conceptualize how supportive an area is to cognitive health among aging residents. Cognability incorporates a constellation of both positive and negative neighborhood features related to physical activity, social interaction, and cognitive stimulation in later life. The positive neighborhood features for physical activities include recreation centers, walkable destinations, and parks. For social connection, it includes social organizations, senior centers, restaurants, and cafes. And for cognitive stimulation, theaters, museums, libraries, and campuses. And barriers or hazards include fast food highways and polluting sites. And so they created a cognability score for every urban and suburban census tract, which is a small geographic area of about 4,000 people in the United States, on a scale from 0 to 100. And the cognability score predicts how well a neighborhood supports cognitive health through the presence or absence of key places. They scored areas by comparing them to one another, and so the average census tract gets a score of 50, and above average areas score higher, and below average communities score lower. And I've just looked up the cognability scores for suburbs in San Francisco, which were mostly blue, so they had a high to very high cognability score. Here is an area in the suburb of Santa Clara, which ranked with 84% very high. It has many civic and social organizations, average amount of art sites, but also very low in highways and polluting sites. Apologies for the small font. There's no need to read everything, but the website shows you this table with exact numbers of neighborhood features per 1,000 people living in this area. And here, just for comparison, just a few blocks further in an area with a very low cognability score of 16%, driven by very few social organizations and a very high number of polluting sites. So projects like these are very interesting when data on dementia prevalence, incidence, and care provision can be linked with these data sets. So it will give a powerful evidence base for policymakers and government. An Australian study led by colleagues from Canberra investigated associations between the built and social environment with diagnosed cases of dementia and with an estimated dementia risk. And they also investigated spatial variation in dementia risk and in diagnosed cases across neighborhoods. The study population here were 25,500 patients aged 65 and older from 16 GP practices in Adelaide. And they found that air pollution, measured by nitrogen dioxide or NO2, was associated with both a diagnosis of dementia and with an estimated dementia risk score. The spatial cluster analysis showed that there was a lot of spatial variation in the estimated future risk of dementia, here on the left-hand side, and in diagnosed cases of dementia patterns on the right picture, suggesting a possible link between built and social environment and the clusters. The red areas are the hotspots and the blue areas are the low spots. So investigating spatial clusters and exploring drivers of dementia clusters generates an evidence on spatial variability of dementia risk and of diagnosed cases, and potential link with the natural and built environment characteristics of an area. And dementia cluster maps highlight also local variations in dementia pattern and understanding of place effect on health outcomes. So they can generate new knowledge for local policy planning and geographically targeting of interventions. We need more research, not only to assess and reveal social determinants of health in aging and dementia, but also we need to develop evidence-based tools and ways to assess health inequities and improve quality of life. And one area of research that needs to get more attention, especially in Australia, is social prescribing. And Suraj has already given some great examples on social cognition. Social prescribing is a means for healthcare workers to connect patients to a range of non-clinical services in the community to improve health and well-being. It's a more holistic approach to healthcare, which promotes community-based integrated care. Social prescribing involves referring people to services and supports to address social needs such as food or housing and financial insecurity and social isolation or loneliness. And social prescribing has been widely implemented now in the UK and in the US, where there's typically policy and funding support for adoption and scaling of social prescribing. Australia's National Preventative Health Strategy includes embedding social prescribing in the health system as a policy achievement by 2030. And social prescribing is also included as an action in Australia's primary healthcare 10-year plan. But while there is local level action on social prescribing, there is the lack of a systematic approach to the design, development, implementation, and funding of social prescribing in Australia. There is an increase in studies looking at social and structural determinants of health in aging and dementia, especially literature on social networks, isolation, and loneliness is growing. But there is still a lot of work to do. So listed here are some areas that lead to health disparities across the lifespan that needs further research. And I think this quote from Atkins-Jackson's paper is a good reminder of the magnitude. Health and its associated outcomes are never individually centered, but are products of exposure to certain risk factors in varying magnitude, from cells to cities, from neurons to nations. The future research directions in this area, in particular in the Australian context, include neighborhood mapping and risk of protective factors and related outcomes such as prevalence and incidence of dementia and brain pathology. Developing a clear understanding of how neighborhood environments are linked to cognitive decline is an important task to understand population health disparities. And combining this approach with data linkage would help to get a better picture of the aging population and help inform the development of specific targeted policy and intervention strategies to improve healthy aging and dementia outcomes. The development of appropriate measurement tools and toolkits is also an important area. As research into social determinants of health in aging and dementia expands, it's important that researchers use standard tools for measurement to help with comparing, sharing, and combining data from different studies. Intervention studies are needed, and in particular, social prescribing is an important area, especially in the Australian context. And as I mentioned before, there is a lack of a systematic approach to the design, development, implementation, and funding of social prescribing. So there is lots of work to be done. And finally, a social policy analysis, identification of policy measures along with evidence of their efficacy and the best implementation strategies that can address the most salient social determinants at the local, state, and federal level. To conclude, assessing and addressing social determinants of health in aging and dementia is essential to improve the well-being, quality of life, and health of older adults with and without dementia. We need larger scale efforts to reduce community-level disadvantage and disparities to promote healthy aging and dementia prevention. Social determinants of health in aging and dementia is a broad field with many promising and interesting yet neglected research areas. I could only give you a very brief snapshot of selected studies, and of course there's so much more that I couldn't present in the time ahead. But as I said, this is a new research direction for me, and here at Shiba, we will start several projects on this in the coming month. So if you are interested in collaboration, please get in touch with me. Interdisciplinary research in this area will be crucial. And one important area that I couldn't even touch on today is, of course, stigma around aging and dementia. So I would like to end my talk with a quote from David Bowie, that aging is an extraordinary process where you become the person you always should have been. Thank you.
Thank you so much, Suraj and Simone. I think we have a few minutes to answer some questions. So perhaps we get straight to these Q&A. And Suraj, you're first in the firing line. I don't know whether you've seen the Q&A, but starting with the first question, I think you touched upon this slightly as well in terms of sensory impairment and how does that affect social cognition and what do you do in a person with sensory impairment? So maybe start off with that.
Sure, thank you, Parminder. So the question in the chat is, I wonder how much other age-related changes like decline in eyesight and possibly hearing could be factors in reduction in social perception as we age. And the answer to that question is We don't know empirically to what percent that would impact it, but certainly when we speak to everyone in our study, either in the co-design group, advisory group, our participants, they all say the same thing, which is that, you know, if they have sensory difficulties, they're finding it much harder than before to interact with other people, especially when people are starting to lose their hearing. The first thing that they find difficult is hearing someone when they're in a group, because it's hard for them to pick out one person's voice over all the noise coming from other people and around them. So I think it's really important, and people tend to lose their confidence. And a lot of people have said to me, now I just do one-on-one catch-ups because I can't hear people when I'm in a group.
Okay, thanks, Suraj. So to you, we stay with you, Suraj. Next one is also to you in terms of acceptance, really. When you actually take these people into your groups, do they accept that they have problems with social cognition, or is that not an issue?
Well, that's a really good question. And I think we try to frame it in a re-ablement perspective. And we say, look, everyone has these skills. We definitely don't want to offend anyone and say they don't have these skills. I think that would be the wrong approach. And so we try to say, well, you know, you're doing really well in certain situations, but you might find certain situations tricky now. And other people might find other situations easy. So if you're in a group, you can share your expert advice with each other. And that way everyone wins. And that's the way we try to frame this.
There's a corollary to that, I think, and it's just come through in terms of outcomes, group versus one-to-one. What do you think?
I think, you know, while one-to-one settings could be helpful, I think rolling out interventions, I always think from a clinical perspective, groups are the way to reach more people, and you get different perspectives and people can share their knowledge with each other. Like you said, Parminder, there's a similarity here. And I think really they learn more from each other. Our slides and our information really just serves as a springboard for them to tap into the knowledge they have as
Sure. Okay. There's a question maybe briefly on this in terms of addressing communication difficulties. Suraj, early on in your interventions, do you actually look at that in terms of language expression, comprehension, etc.?
Yes, we do. So our first couple of sessions are focused very much going from the basics, like making eye contact, smiling, introducing yourself, how to start a conversation, how to keep a conversation going. What do you do when you can't find that word you just have at the tip of your tongue and now you're losing your confidence, how to deal with all of those situations, and also how to, you know, bring back a little bit of your social filter in those situations.
Sure. Okay. Michael Woodward has sent two questions. I'll pick one, I think, and then maybe we come to Simone. She's feeling neglected to some extent. No, okay. But in terms of ASD, autism spectrum disorder, and dementia, really, because these people are bringing in a lot of problems with social cognition and social interaction previously. Firstly, of course, does that worsen their risk or increase their risk for dementia? How do you then deal with that, really, in terms of people who already bring those disabilities through their lifespan? Yeah.
Again, a really good question. And I'm afraid I don't really know the answer for whether people on the autism spectrum are at higher risk of dementia, but I would guess that because they tend to have other risk factors as well, not only difficulties with social communication, but also higher risk of depression, anxiety, other health conditions, that I would expect them to be overall slightly at higher risk, but I don't know. I think what they find especially difficult is confidence in these social situations, because sometimes without a script and having a topic to speak about, they can feel quite anxious in those situations. And actually, a lot of interventions that I've run in the clinical setting are social skills groups for children with autism. There are one or two programs that are for adults with autism as well. So there are those things out there to help people to communicate in those situations and find their confidence again.
Sure. Okay. And maybe finally, yes, because there's a sort of dual, two people asking this question, the difference in social cognition between behavioral variant FTD and the frontal variant so-called of AD. So do you think there are any studies on that? And can you comment on that?
I've tried really hard to find studies that have enough sample sizes to be able to tell those apart, but all I've found so far are studies that look at behavioral variant exclusively or dementia exclusively. There's very few studies out there that compare them, and that's work that we still need to do.
Yeah, so it's a study to be done, really. Yeah. I think coming to Simone, I mean, you talked about the life difference in life expectancy for between white Australians and indigenous populations, really.
Yeah.
But we also see a major difference in their dementia rates, and a few studies that we have, so that there will be actually a threefold increase or so in the rates of dementia. And what is you think it's largely social determinants there as well?
Yeah, it definitely needs a lot further research to look into the details, but I think social determinants is definitely a big factor there, because it's a lifespan approach, and indigenous people are usually disadvantaged from birth or even in utero, and so when you look at the whole lifespan, this leads to an increased risk of dementia, to a higher level of morbidity and mortality, and earlier death as well. So it's a whole bunch of factors that contributing to this.
Okay. So this question from Jenny Phillip. Dementia Australia runs memory lane cafes, which have people with dementia and their loved ones attend in social setting. It provides many positive outcomes, including peer support, etc. However, it would be interesting to know if the social outlet has ongoing outcomes that you have outlined. I don't know whether there's been any research published on these memory lane cafes that you're aware of?
Not that I'm aware of, no.
No, neither, Suraj, okay. So in the US, neighborhoods tend to be more racially and socioeconomically divided. So do we know if the cognability findings apply here in Australia?
Yeah, that's interesting, and it's true that the US have a lot more diverse population than we have, but I think it depends on which area you look at and how deep you dig. So there are here also many areas that have a high number of housing commissions, people with more cult background, and socioeconomic not as stable as in other areas. So I think Australia has kind of a diverse population if you dig deeper, but it will be important to really look at a small scale neighborhood level, because when, for example, you look at South Coogee here, there is a lot of housing commission, but there's also a very wealthy area. So, and they are both combined in one area. So it will be really important to look at it and control for the difference.
Yeah, and the approach that you mentioned, the Canberra group, they're looking at dementia atlases, or
yes,
atlases really, it looks at the social indices, etc. And that probably is a good approach in trying to look at effects of social development. So I think we're over time. Johannes is being very quiet here, but obviously I want to thank you all. I just will end with just a couple of things. One is, of course, that I want you to actually look at providing some feedback. An automatic survey will automatically open in your web browser after exiting the webinar. And so please take some time to complete it. It shouldn't take very long. And the completion certificate will be sent to you via email. Make sure to provide your email. And then, of course, our next webinar would be conveyed to you very soon. It's not been finalized, but do keep an eye out for the next posting. So I'm sure you've enjoyed this. I want to thank Suraj and Simone for excellent presentations, and for the great work that both of them are doing. And thank you all for attending.